Okay, everyone, we are starting with the last piece of our lecture on lymphomas. We are going to take a look at Hodgkin's disease, which is more prevalent among 15 to 19-year-olds. And then we're also going to look at non-Hodgkin's lymphoma, and this is more prevalent among children less than 14 in age. Hodgkin's disease, it's a neoplastic disease. It originates in the lymph system. It primarily involves just the lymph nodes. We often will see metastasis to the spleen, liver, bone marrow, and lungs. If you guys look on page 1312, there is figure 44-4. These are the main areas of lymphadenopathy and organ involvement with Hodgkin disease, and the clinical manifestations are basically what we see according to the lymph nodes of the area that's affected. We look at staging and prognosis. Accurate staging is the basis for treatment and prognosis. There is more than one staging system available, and improved treatment and staging has improved the survival rate. There is another box on page 1312. It talks about the different stages of Hodgkin's disease, stage 1 through stage 4. Stage 1 is best, stage 4 is the most severe. And again, you guys know we look at the staging and it'll determine what treatment course we're going to put them on. All right, the diagnostic evaluation of Hodgkin's disease, the clinical manifestations, we look at those: painless enlarged cervical or supraclavicular lymphadenopathy, so enlarged lymph nodes in the cervical region or around the clavicles. We look for complaints of cough, abdominal discomfort, anorexia, fever, weight loss, night sweats. Our diagnostic evaluation is a history and physical based on the symptoms. We look at the CBC, we look at their uric acid levels, their liver function, their C-reactive protein or their SED rate. We look at the alkaline phosphatase. We also could look at a UA, and then there are certain radiological tests that we can do. When we find those enlarged lymph nodes, we typically biopsy those, and if it's Hodgkin's disease, they will have the presence of the Sternberg-Reed cells on that biopsy. The therapeutic, oh, I forgot to flip my slides again, guys, sorry. There was your diagnostic evaluation of Hodgkin's disease. I talked about the clinical manifestations and what diagnostics that we used. Now let's talk about the therapeutic management of Hodgkin's disease. Radiation, chemotherapy. Chemotherapy can be alone, or we could use it with radiation. Prognosis, long-term survival is excellent. Aggressive therapy increases chances of complications. And if you think about the therapy, that's radiation and or chemo, or both of them. In the more that you're exposed to chemo, the higher doses, the more severe are the side effects. And then if you're adding radiation on top of that, again, more side effects of that. Care management for our Hodgkin's disease patients would be prepping them for diagnostic procedures. So again, the radiologies, the blood work, and then obviously the biopsy. The side effects of the chemotherapy, the side effects of the radiation, family support, and then there is a concern for high risk of infertility. Again, think about your age groups that we're treating. We said anywhere less than 14 and then 15 to 19-year-olds. Again, the 15 to 19-year-olds for Hodgkin's disease is our target group here, and again, that risk for infertility. All right, non-Hodgkin's lymphoma. This occurs more frequently in children than Hodgkin's disease. The clinical appearance of a patient with non-Hodgkin's lymphoma, the disease is usually diffuse rather than nodular. Cell type is either undifferentiated or poorly differentiated. Dissemination occurs early, often, and rapidly. We can see with non-Hodgkin's lymphoma mediastinal involvement and invasion of the meninges. Again, there is staging again for non-Hodgkin's lymphoma. That is on page 1313, and it is stage 1 through stage 4. And we look at the staging. We look at the histologic presentation of this lymphoma, and it tells us about their stage. Let's see, prognosis is improved with a young age, low mediastinal involvement, low tumor burden, and if they have a good response to the initial therapy. Clinical manifestations of non-Hodgkin's lymphoma, it really depends on the anatomic site involved, like it did with Hodgkin's lymphoma. Metastasis to the bone marrow or CNS may appear like leukemia. Diagnostic evaluation would be surgical biopsy for confirmation of the disease. They could do a bone marrow aspiration, radiologic studies such as a CT scan of the lungs and the GI system. And then our care management would be therapeutic management of non-Hodgkin's lymphoma, aggressive radiation and chemotherapy. And again, don't forget about the phases: induction, consolidation, and maintenance. And they could also do some intrathecal chemotherapy here. The primary focus of our care management of non-Hodgkin's lymphoma is just managing those side effects of chemotherapy, which we have talked about before. All right, you guys, that concludes the hematology immunologic lecture, and I will make sure you're following along in the chapter and only focusing on the content areas that I focused on. If you guys have any questions, let me know. Thank you.